what does in utero exposure? So what happens is diabetes, everybody knows that diabetes is a state of insulin resistance or basically hyperglycemia. Now, what does this in utero exposure of hyperglycemia lead to? Be the situation, this hyperglycemia prior to pregnancy in the preconception period or during pregnancy, what does it do? So can anybody answer? Answer in this, all of the above, exactly. So it will increase the fetal fat cells, and it will cause fetal hyperinsulinemia, and it will cause the insulin resistance in adolescents also. So the situation is the hyperglycemia, whether it is preconceptionally the lady is hyperglycemic or whether she develops hyperglycemia during pregnancy, she will always have a risk of the development of hyperinsulinemia in the fetus, and in later stages, once the baby is born in adolescence, the insulin resistance of the baby. And how is diabetes classified during pregnancy? How is diabetes classified during pregnancy? Please answer in your question box. So when we talk about during pregnancy, so it can be either pre-gestational or gestational. Okay. So the answer ideally should be type 1, type 2, or type or gestational. So let's, as I have not prepared my own, so I am just presenting it from here. So diabetes in pregnancy can either be pre-existing diabetes or gestational diabetes. And the pre-existing can be type 1 or type 2, and gestational is either pre-existing diabetes or true GDM. So you everybody knows this. And so what is the difference in both of these is, so when the maternal hyperglycemia exists pre-existing, when the maternal hyperglycemia is happening during pregnancy for the first time in the pregnancy, it will result in fetal hyperglycemia, which will cause a fetal these are the three major important complications, 4 major important problems which will happen if the hyperglycemia happens for the first time in the pregnancy. Okay, there will be fetal hyperglycemia. Because of the hyperglycemia, there will be fetal osmotic diuresis, and because of which it is going to cause polyhydramnios. So you will have polyhydramnios. And because of fetal hyperglycemia, there will be decreased cortisol production, resulting in decreased surfactant synthesis in the lung, which will result in respiratory distress syndromes. When the babies are born, they have respiratory distress syndrome way more as compared to a non-diabetic mother. And because of the fetal hyperinsulinemia, there will be fetal hypoglycemia because of the insulin levels being raised, resulting in insulin-like growth factors to be on a higher side, causing fetal macrosomia. And this macrosomia, everybody knows, is more characteristically on the shoulder level, at the back of the shoulder, in the interscapular region. That is going to cause obstructive labor or shoulder dystocia. And when the baby is born after shoulder dystocia, Erb's palsy and birth asphyxia, and these are all legal matters. If the baby is born with Erb's palsy, the mother can actually sue the doctor also. Medical negligence can happen. So these are all, this is the case scenario if the maternal hyperglycemia happens during pregnancy and not prior to pregnancy. This is extremely important to understand why the hyperglycemia during pregnancy is causing all these things. So you now understand. But if the hyperglycemia is pre-existing, so in those case scenario, because she is already pre-existing hyperglycemic, preconceptionally she is hyperglycemic. In such a case scenario, there will be impaired organogenesis in the first trimester, causing congenital abnormalities, which will not be present in GDM. So this is extremely important for you to understand the differences between the diabetes in pregnancy and pregnancy in diabetes. So diabetes in pregnancy was the one which I showed prior, that diabetes happens in pregnancy, and first time when it is diagnosed in pregnancy, it is called as gestational diabetes. And any diabetes which is pre-existing before pregnancy in the preconceptional period, that is called as pre-gestational diabetes, which can be type 1 or type 2. And in the preconceptional, matlab pregnancy se pehle hi she had hyperglycemia, that is why that is way more harmful, going to result in impaired organogenesis and congenital abnormalities. Can anybody write me what are the most common congenital abnormalities in the patient who has diabetes and she develops pregnancy with high in can anybody mention this in the question area? Yes, cardiovascular, which is the most specific of diabetes in pregnant, which is the most specific congenital abnormality of diabetes. TGA, sacral agenesis, extremely good, very good. And in chronic maternal hyperglycemia, what happens in chronic maternal hyperglycemia? All these glycosylated hemoglobin, they carry less oxygen molecules, and oxygen binds more avidly and releases oxygen also less. Further, for fetal hyperglycemia, during the entire first trimester, second trimester, third trimester, they will further keep on increasing fetal oxygen demand, and there will be anaerobic metabolism causing a lot of lactic acidosis, and these are the causes. The lactic acidosis is the causes for IUD, intrauterine death, abortions. So they are on a higher increased risk of miscarriages in the first trimester, miscarriage and intrauterine deaths and congenital abnormalities. These are all if the pregnancy in diabetes happens. Can anybody tell me what is the cause of, okay, we'll discuss the question later. So because of these decreased oxygen hypoxemia, there will be increased erythropoiesis also, and there will be polycythemia and hyperviscosity in the baby, and when the baby is born, there will be neonatal hyperbilirubinemia as well. So these are all what I have right now I have discussed is, okay, right now what I have discussed is the patient already had diabetes, pre-existing diabetes, and then she developed this thing. Now, this is a question. Just to diabetes is the most common medical complication. You need to know that it is the most common medical complication, and apart from that, the other most common is this thing, hypertension in pregnancy. Can anybody tell me which is the more ethnic group which has highest risk of gestational diabetes? Please type in the question box. So Native Americans are the most common, most highest risk for gestational diabetes. But we as a group of ethnicity are also at the highest risk, are at a very high risk. And that is why we are always screened. Nobody has answered. Asians, no, Asians. So Asians se bhi zyada ऊपर Native Americans hai, but we need to understand Asians are already also in a high risk population. And that is why the screening is done. Now, patients who are GDM, now, so I am flipping questions here and there. This is just according to this book. So this is a patient who already has diabetes. Now, as you know, the history of diabetes, if already present. So gestational diabetes does not cause vasculopathy, retinopathy, nephropathy, or neuropathy. It does not cause that. But if a patient already has diabetes and then she becomes pregnant, so she is always at a risk of retinopathy, vasculopathy, depending on the duration of diabetes. And that is done by White classification, Priscilla White classification, that is given in your Datta as well. You must be knowing. So can anybody answer this question for me? 34th question. The 34-year-old woman diagnosed with diabetes at the age of 20. So you can see that there is a 14 years of diabetes. She's having a long-standing diabetes. Her 24-hour urine protein is also 250, which is not more. 300 milligram is the cutoff. But she has benign retinopathy on ophthalmologic examination. Now, what is the White classification does her pregnancy carry? Can anybody mention this thing to me? No. So this answer is D. Why? Because benign retinopathy is so, and more than 10 years, 10 to 14 years. Let me open this book for you, your own book for you. Where is the Priscilla White classification? If you can have a look at that. Yes. So this is category D, where you will have 10 to 19 years duration, and there is no vascular disease. Okay, and but there is benign retinopathy, and so this is if there is benign retinopathy, it will automatically come under class D. So can anybody mention me what are the changes in the retinopathy, in the signs? So extremely important. If a patient comes to you and she asks that she's in the preconceptional period and she asks that I want to get pregnant and she's diabetic, so retinal examination preconceptional period is extremely important. Can anybody mention me what are the changes? What is non-proliferative change? What is proliferative? What is pre-proliferative changes? Can anybody tell me? Neovascularization. So proliferation, microaneurysm is the buzzword for for the non-proliferative disease. And then second is the cotton wool exudate. Cotton wool exudates is the pre-proliferative. And what happens? There is a retinal ischemia happens, and because of that retinal ischemia, the body responds to it. And then there is neovascular, new vessels. So the retina is supplied by new vessels, and during that new vasculature development, there sometimes these vessels bleed, and that is basically the proliferative phase, which is PDR, whether no, so all the three phases you should know: non-proliferative, pre-proliferative, and proliferative. And you need to examine a patient who is already diabetic in the preconceptional period itself for retinal examination. And now this question is, which of the following are considered diagnosis for overt diabetes in pregnancy? So tell me, please answer in the question box. No, it is 6.5. HbA1c has to be 6.5. Now mention. So this is how first you have to pick up how to diagnose the diabetes in pregnancy. Now there are three situations. If the lady is already known, if the lady already knows she is diabetic and she comes to you, what level? Yes, the answer is D. That is, the answer is absolutely D. More than random sugar, more than 200. But important part is, with the random blood plasma glucose, you need to have the diabetic features of polydipsia, polyuria. So this is the entire over diabetes in pregnancy. Now, can anybody tell me, if the lady has come in the preconceptional period and she is asking that she wants to get pregnant, at what level of HbA1c, what is the desired level of HbA1c that you would want? Okay, now you can reassure her and tell her that please go and continue and have your pregnancy. And what is that level of HbA1c when you will say no, we would like to terminate your pregnancy even if you are pregnant? Yes, less than 6.5. Less than 6.5 is your desired HbA1c. But at the same time, what is the level when we would even go to the extent of terminating the pregnancy if she's in the early first trimester or even in the late first trimester? What is that? What is that level? Please mention. Please mention. I am not getting an answer. So that the level is HbA1c more than 10. HbA1c reaches more than 10. So what if the patient has come in the preconceptional period and she is diabetic? Now, you will always, what will you do? What will you tell her? What will you tell her that what all she can do to decrease what in the preconceptional period? What all information will you be giving to her? That she needs to have, what is the role of diet, body weight, and exercise. And if she has a not more than 7.5, it is more than 10, she has to control her diabetes. She has to definitely control her diabetes. She needs to understand the risk of hypoglycemia. So the mothers who are having diabetes already, type 1 or type 2, the risk is more when if she gets hypoglycemic attacks. Okay, what happens is, if she has a long standing diabetes, and because of the long standing diabetes, what happens is that the patient in vasculopathy cases, she will not even realize, in the neuropathy and vasculopathy, she will not even realize that there are symptoms of hypoglycemia. So what are the symptoms of hypoglycemia? Please somebody write in the chat box, in the question box. What are the symptoms of a tremors? Yes, more common, right? More common symptoms: dizziness, more common sweating, dizziness and tremors, headache. Sweating is very important. Dizziness, sweating is the most important. Palpitations, yes. So all these symptoms will, even if you're having, you will not realize if there is diabetes with neuropathy and vasculopathy. So it's extremely important for a patient who has come to you with diabetes to inform her that there is a risk of hypoglycemia and there may be impaired awareness of hypoglycemia during the pregnancy. Okay, and then you need to, as I told you, diabetic retinopathy needs to be assessed before and during pregnancy. There will be nephropathy needs to be assessed. These are all in the cases if she has diabetes prior to pregnancy. Okay, and then the maternal glucose control has to be there. If she is planning a pregnancy, we will advise her that she can now Okay, if till the time she has her, she has to use contraception until they have a good glucose control. As we told, she has to have a good glucose control, and you told HbA1c has to be less than 6.5. So in case who has diabetes and if she has a BMI more than 27, so tell me what is the this is not obese. What is the classification? When does the obesity? What at what BMI does the obesity start? Obesity as it starts at 30. Very good. But if the patient already has diabetes and her BMI is above 27, you will definitely advise her to lose weight. It is extremely, extremely important. And you will tell these patients to take diabetes, the patient who already have diabetes, to take folic acid 5 milligram per day until 12 weeks. Normally, you must have read that patients who have previous NTD or previous who are anti-epileptic drugs, they should be taking folic acid, high dose folic acid. But patients who have diabetes also need to take high dose folic acid for the entire first trimester. Okay, and even who are planning to take planning a pregnancy also, they also need. So what we have understood till now in the preconceptional period, BMI, if she's already diabetic, she needs to be explained. She needs to be explained how that what are the hypoglycemic symptoms, and there if she has a long-standing diabetes, she might not understand the she might not be aware of the hypoglycemic symptoms. And if BMI is more than 27, she needs to lose weight. Folic acid, high dose folic acid. These are all simple things that you need to tell her. She needs to control her blood glucose. HbA1c needs to be brought down below this. And I have already told you what happens with the hyperglycemia. We have discussed that before. What happens with the hyperglycemia? Congenital anomalies. You have already mentioned what congenital anomalies will happen. And if that hyperglycemia continues, there can be miscarriages, intrauterine, and because of lactic acidosis. And then also later stages also it is not easy because of the maternal problems will also keep on increasing. Then as we told, the target blood glucose levels, this is basically in millimole per liter, which is a UK standard. You can convert this into these are for type 1 diabetics, that these are the standards. You may write these values and then you can see the conversion also, and put this up. So as you had told that 6.5, basically HbA1c is 6.5, it needs to be less than 6.5, that is below 48 millimoles per mole. But at the same time, fasting sugars also need to be less. This is basically around, it has to be less than 126. You cannot go up at sugars like 126, that becomes impaired. So you need to be bringing down the fasting sugars less than 110. And so 5 to 7 should be fasting, and plasma glucose 4 to 7 before meals. Okay, we can have a conversion into milligram per deciliter, and this is the one which I was telling you. That is why if the HbA1c is already above 10%, that is 86 millimole per mole, then we will not advise her to get pregnant until it is HbA1c is lower, because of the associated risk, as we mentioned, congenital abnormalities and miscarriages. So these are, and folic acid 5 milligram is extremely important. And since in type 1 diabetics, obviously, what is the drug of choice? What is the drug of choice for type 1 diabetics? Can anybody mention in the question box? What is the drug of insulin? Extremely good. And what is the drug of choice for type 2 diabetics? Because usually type 2 diabetics are a little on obese side, metformin. But can you continue metformin in the pregnancy? Can you continue metformin in the pregnancy? Can somebody tell me? So, metformin is the only drug which can be continued in pregnancy, and studies are ongoing for glibenclamide is already going on, but the only drug which has been tested. So, if a lady already has diabetes, type 2 diabetes, she's already taking metformin, so you would like to continue metformin. But if she's not able to continue, but if she's not able to withstand the side effects of metformin, we would like to change it. Okay, so metformin is the only oral hypoglycemic drug which can be continued in pregnancy, and no other. Otherwise, the drug of choice, if we asked you, is insulin. Okay, and as I told you that retinal assessment needs to be done before pregnancy, renal assessment needs to be done before pregnancy, and this is what we were dealing with the pre-existing pre-existing diabetes. Okay, now this is not an important question. Okay, so this is, how does diminished fetal growth occur in pre-gestational diabetes? How does diminished fetal growth occur in pre-gestational diabetes? So this you have to tell me. Can anybody answer this question? Change to what drug? If we change to what drug if metformin has side effects? Insulin is the drug of choice. So we will try giving metformin. If she's controlled in metformin, that is the best. If metformin, then we change to insulin. Okay, but we have to see again all the patient. Yes, the all the above. No, basically there is the answer to this question is majorly what happens is substrate deprivation. I had shown this slide to you that there is a lot of increased fetal demand and there is a lot of anaerobic metabolism in the pregnancy, and because of chronic maternal hyperglycemia, and thus the at a basic at the tissue level there is substrate deprivation which happens in the diabetes with pregnancy in diabetes cases. Okay, now this is not an important question. Okay, this is a baby. This is a case scenario. What might be said of the pregnancy yielding this 5 kg newborn? The mother likely had a poor glycemic control. The baby was at a risk of neonatal hypoglycemia. The mother had a risk for shoulder dystocia. So, what do you think? What is the answer to this question? So, this is a 5 kg which is born. Yes. So all of the above can be there. So poor glycemic control will also result in macrosomia. So we need a good control. So now what control do we want to have? All of the above is the answer. Yes. So what good kind of good control? Do you want to have a very extremely tight control or you want to have just a good control? So you would not want to have an extremely tight control because hypoglycemia events you want to avoid, and this goes for both gestational and diabetes also. And the baby will obviously be at a risk of hypoglycemia, neonatal hypoglycemia. Can anybody tell me why neonatal hypoglycemia develops? Can anybody tell me why once the baby is born, why the neonatal hypoglycemia develops? Hyperinsulinemia? No, that is not the answer. Insulin levels are high. So what happened? Islet cell hyperplasia, extremely good, because during when the baby was inside the mother, so the insulin was being passed, the hyperglycemia of the sugar, the mother's sugar was going into the baby, and in the baby over this entire time period, the baby's islet cells were hyperplastic. They become hyperplasia. So this is the pathology. The basic pathology is islet cell hyperplasia happens, and then immediately the mother's glucose gets cut off when the baby is born, and only left is the insulin. So high insulin levels, the levels of the insulin are not high, it's just the glucose goes low, the supply of the glucose goes low, the insulin level is the same. Okay, and the mother had increased risk for shoulder dystocia. So now why shoulder dystocia? Again macrosomia, and macrosomia where? At the shoulder pads. Okay, and what is the first step that you show that you say happens? What is the first step if the shoulder dystocia develops? What is the first step that you will do? Nobody is messaging, nobody is writing in the answer the question bank. We have very less time, we have to cover a lot. Help, call for help, very good, call for help. And then what is the first maneuver that you will do? What is the first maneuver? What is the first maneuver that you will do? It's Mac Roberts maneuver. Yes. Now this question, read this question. Which of the following are considered reasons for unexplained fetal demise? This is a very important question that they will ask you in women requiring insulin in pregnancy. I have told this question to you. How would the beta cell hyperplasia cause normal insulin levels? Because those insulin levels were normal for that level of glucose, and the baby extracts glucose directly. So they were fulfilling the baby's requirements. So at that particular time, when they in the intrauterine period, those glucose levels were normal for that baby, and that insulin level was normal for that glucose. So what happens is the glucose shuts off, the insulin level is remaining the same. There is no increased insulin, new insulin is not being secreted. It's just what was existing. Yes, exactly right. Lactic acidosis, what was already existing, that causes result that results in hypoglycemic episodes. Okay, and that is just for the first 48 hours. After that, everything gets balanced. What is a reasonable explanation for hydramnios in a pregnancy complicated by diabetes? So now this is GDM. Now this is pregnancy has diabetes. So what will be the reason? What will be the reason? Yes, absolutely right. Osmotic gradient. We just studied this. And what is the most likely cause for increased incidence of respiratory distress syndrome in the neonates of diabetic mothers? Can anybody tell me? So this is, they are asking you most likely cause. So they're asking you most likely cause. So they are responsible factors, no doubt, but the most important is indicated preterm delivery. But because we do not wait, now we will understand the management. Once we will go there, we will understand the management, that in majority of the cases, we have to deliver the baby, and that is why. Because if we take the pregnancy in GDM, in pregnancy, when we take the patient to the term, the respiratory distress syndrome will not be there. The respiratory distress syndrome will not be there. There is decreased production of surfactant in a hyperglycemic environment, that is absolutely right. But if the diabetic mothers are taken, they're very well controlled, sugars are there, and you take it to term, they will not have respiratory distress syndrome. So this is, you need to understand, iatrogenic preterm delivery is one of the reasons. Okay. And then this is important. uh, Another question which was important is, okay, I think we are good to go. Which of the following infections increase in pregnancy with overt diabetes? Tell me this question, 20th question. Which of the following infections are increased in a patient with overt diabetes? All, absolutely right. So extremely important is that urinary infection, and these females will present with, irrespective if she's over diabetic or she develops diabetes in pregnancy, that is gestational diabetes. If she develops gestational diabetes in pregnancy, in all these case scenarios, she will have curdy discharge, candidal discharge, urinary infection, respiratory infection. They're more prone to have respiratory infection. They, even in the postpartum period, wound infection. Diabetes itself is a state of immunosuppression, all infections increase. So everything is there. Most difficult aspect of the preconceptional control in women with diabetes is which of the following? Okay, this is not an important question. What women with type 1 diabetes achieve glycemic control in with which of the following during pregnancy? So type 1 diabetes means insulin. So there is nothing, no doubt about it. Okay. And then I think we have another few questions I had. Okay, which of the following defines gestational diabetes? So now first all of, oh God, what happened? First, all of you write, some of you write, please. How did you diagnose overt diabetes? What are the diagnoses of overt diabetes? How will you diagnose overt diabetes in pregnancy? No, not OGTT, overt diabetes. I'm asking about overt diabetes. How will you diagnose overt diabetes in pregnancy? This OGTT we will see, but how will you diagnose or random blood sugar? Yes, one of the reasons is random. One of the diagnosis is random blood sugar. Absolutely right. What other methods? Random blood sugar, fasting, HbA1c more than, say, fasting more than 126. Extremely good. These are all the possible reasons. Now we come to gestational diabetes. Now we come to gestation. How is gestation? But why will you diagnose? Why will I think that she will have gestational diabetes? What will be the reason? First, what will be the reason I will check her for gestational diabetes? There has to be some reason now. Why will I check her for gestational diabetes? When BMI is more than 25, she is overweight. When there is an excessive weight gain in pregnancy, she had previous pregnancy, previous glycosuria is not an indication. Previous pregnancy had GDM. She has family history of diabetes. She's a South Asian ethnicity. She has now family history of diabetes in the first degree relatives. So these are all the risk factors. Since we belong in India and we belong to a South Asian population, our ethnicity has a high risk already. That is why we check in our Indian, according to as per our Indian guidelines, we check the all the females for GDM. We check all females for GDM. Whereas if you will shift to US or UK, they will only check for high risk patients. They will only check for high risk patients, and high risk patients mean they will screen them and they will take their history. Do they have the history of GDM in the previous pregnancy? Do they have a family history of diabetes? Did they have a macrosomic baby in the previous pregnancy? And those factors will decide whether they want to do the GDM OGTT or not. Okay, so this is important, and we had already discussed this. First trimester, second trimester, you already know, understand. Complications and Priscilla White classification we understood. We told, I mentioned you, benign retinopathy changes is grade D, and GDM. So these are very, sometimes these are very, most of the patients are asymptomatic. Okay, most of the patients are asymptomatic. And now what is the time frame when you will check for GDM? Now you have mentioned that glucose challenge test will be done, but now when will I check for GDM? You tell me. Now there is a patient who has come at 12-week pregnancy for the first time to me in the OPD, and she asked, ma'am, and then you've taken the history. History is completely negative, and she's completely no history of diabetes in the past, no family history of diabetes. So will you do her glucose challenge test? So who should be? So who should be tested? So who should be tested? The first antenatal as early as possible, and the second testing is 24 to 28 weeks. Okay, the high risk cases can be tested, and all pregnant women who to be tested even if they come late in the pregnancy. Okay, first visit. Since we are a high risk population, we will do as early as possible as well. And in India, we do the DIPSI. So that is given in your this thing also, book also, that you will do DIPSI, effects of diabetes. That you will do DIPSI management. No, 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 no. It is given prior to this. Yes, this DIPSI is to be extremely, it is the most important, and it is the only thing that you have to remember. Rest remaining, if you want to remember, they are all going to be for theoretical purposes. But DIPSI, if you don't know, that is not, because in India we follow DIPSI only. It recommends one step procedure with 75 oral glucose without the regard to time of the last meal. That is fasting. It does not make a difference. And a venous plasma glucose, not a capillary, venous. You don't do it by glucometer. At 2 or more than 140 milligram per deciliter is diagnosis of GDM. So this is how you will diagnose GDM. Okay, any doubts in this? So what is the answer to this question? Which of the following defines gestational diabetes? A, absolutely right. Diabetes that is first detected in pregnancy, any sort of diabetes that is first detected in pregnancy, whether it's type 1, type 2, or anything pre-gestational, even if it is diagnosed first time in the pregnancy, it is called as gestational diabetes. This is one question which I used to be confused, that if you find the type 1 diabetes in pregnancy, would we call it that? Okay, would we call it gestational diabetes? Yes, we will call it gestational diabetes only. Okay, and then in women with gestational diabetes, early fasting hyperglycemia is associated with the increased risk of which of the following? Any answers? Any answers? Early fasting hyperglycemia. Early fasting hyperglycemia is associated with increased rates of which of the following? It is associated with all of the above. There will be an increased risk of cesarean delivery. There will be an increased risk of fetal macrosomia, and there is increased risk of maternal hypertension as well. And which of the following factors have been implicated in the fetal macrosomia? We have discussed this already. We have discussed this already. First, let's say the most common important factor is insulin-like growth factor, but there are others are leptin and C-peptide as well. So the answer will be all of the above. Okay. Now we move on to once we have tested this patient. So there are other universal testing. We will discuss it. Other universal testing. We have 2-hour plasma. If it is positive, then you will manage at GDM. But if it is negative, you will repeat the testing at 24 to 28 weeks. And if it becomes positive, then manage as GDM. But if it becomes less than 2140, then we will manage as normal patient. And now we will go to the management. Now we will go to the management. Okay. So as we have discussed the previous macro, these were the risk factors as we have discussed. These are the risk factors. And glycosuria, as you had told, glycosuria detected by routine antenatal testing. Glycosuria, we will, if it comes on 2+ or on 1+ on 2 or more occasion, we will then check gestational diabetes. Then we will check her by the testing. Okay, 75 OGTT 2R value, that is the most important. Dipsy is the most important. Now these are the other, this is the in millimole per liters also. I used to remember this by 5, 6, 7, 8. If you want to remember, you choose to remember this. This is decent enough. This is again 7.8 is basically what we discussed, 140, 140. Okay. Now what happen is, once we have diagnosed GDM, so immediately first you will explain the woman what is that, what is you have, what you have, gestational diabetes. First you will explain the implications of both short term and long term on diagnosis of the pregnancy, of the diagnosis. Now you will all at the same time you will explain that the baby also has a chance of gestational in pregnancy. If she is a female, gestational diabetes, the baby also will have a chance in adolescence to develop diabetes. All this you will explain, all this. And the short term, that the baby will have respiratory problems, and there will be the risk of shoulder dystocia. You will explain everything. Now that good glucose control is required throughout the pregnancy, that will reduce the risk of. So this is important, this is extremely important statement. Why would she want to explain, have a good glucose control? She will ask you, madam, agar thoda bahut upar niche ho bhi jata hai, so she brings you these records which are like haywire, and she's having glucose postprandially 160, 170, fasting is 120, 130. So you will have to tell her that a good glucose control will help to reduce the fetal macrosomia, trauma during birth for her baby. There will be decreased induction of labor, decreased chances of cesarean section, decreased neonatal hypoglycemia, and the perinatal death. These all are increased if the mother's sugar values are haywire. And then we need diet and exercise also. You will tell her to how to monitor self monitoring of blood glucose. So we tell our patients to buy, if they are affordable, then we explain them that buy a glucometer and standardize. We need to calibrate the glucose levels also with the standard venous levels also, and then use the same capillary plasma glucose levels with the target levels. Okay, now here capillary plasma glucose are the target levels which are used. Okay, we will come down at that. So you will give her MNT, medical nutritional therapy is given, and by that you will give her changes in the diet and exercise. She has to be advised to eat a healthy food during pregnancy, switching from high to low glycemic. Can anybody mention the types of high glycemic index and low? What are the high glycemic index foods that she needs to avoid? Please mention watermelon. No, I'm asking for high glycemic index food. Yes, mango. Yes, more importantly, mango, sugary foods, ice cream. So हर patient ice cream और sugar नहीं खाती है. The most important that she eats in her meal is rice. Rice is one of the most common foods for the patient population that you are dealing with, because it is easily available in bulk, and it is moderately costed as well. So rice is extremely starchy food. Okay, and all these things that you mentioned, pasta and chiku, they all have. So that is good. Now you will refer all the patients of diabetes, gestational diabetes, to a dietitian, and you will tell them to exercise regularly. For example, walk 30 minutes after a meal. Anyhow, we should also all develop this habit to walk for 30 minutes after a meal, but this is extremely important for gestational diabetes. Now if okay, let's not read this now. If we can give a trial. So I had told you in the beginning that if the patient has type 1 diabetes, we will definitely go for insulin, but if the patient has type 2 diabetes, she is already on metformin, we can go for we will continue her metformin. We can continue her metformin. If she is not tolerating, we will switch over to insulin. In gestational diabetes, what you do is, in gestational diabetes, first you will go for diet and exercise. You will give her 1 to 2 weeks. If it controls with 1 to 2 weeks of diet and exercise, it is very good, it is the best. And then if the blood glucose targets are not met with diet to in 1 to 2 weeks, we can offer her metformin. So this today, since we know that metformin is an extremely good drug, we can offer her metformin also. So nobody will ask you any questions why this is not given, which book, this, that. Nobody is going to ask you. Metformin is a standard drug which can be offered to any patient of gestational diabetes mellitus, but it is an off-label use. Okay, but if the metformin is contraindicated or unacceptable, then you have to go for insulin, as you had somebody asked that question. And if blood glucose targets are not met with diet, exercise changes plus metformin, then we also have to go for insulin. But now what happens is sometimes if the patient comes and you did the OGTT and her levels, her fasting level only was more than 140, 7 millimoles per liter. That is, we have fasting level is more than 126 only. So like she's overt diabetes. We cannot waste time. She's already been overt diabetic. You don't know how long, because we don't have HbA1c levels at that particular time. So if she has come and she's come with a high fasting sugar levels of more than 120 in the range of overt diabetes, what we will directly immediately start the treatment with insulin, with or without metformin. You will parallelly start diet and exercise, but you will not wait for diet and exercise changes for 1 to 2 weeks to act and then. So these are the two differences between. This is one big important difference between diagnosing overt diabetes in pregnancy and diagnosis gestational diabetes in pregnancy. Now, if gestational diabetes in pregnancy, later on after the postnatal period, we can diagnose that pregnancy to be type 1 or type 2, doesn't make a difference. Any pregnancy diagnosed in any diabetes diagnosed in pregnancy has to be called as gestational diabetes only, and it can be because of pregnancy itself. Okay, I have not asked you why the what happens in pregnancy, what as such happens in pregnancy that the gestational diabetes develops. What is that particular thing that happens in pregnancy that gestational diabetes develop? Can anybody mention? Please write your answers in the question box. I am not getting any answer. Insulin resistance, HPL, exactly. And what happens is this insulin resistance is maximum at the rate type of 24 weeks, 24 to 20. That is why we do the OGTT, and anything that we need to do, OGTT or GCT or 75 DIPSI, whatever test you want to do, you will do it at 24 to 28 weeks. It is extremely important to repeat the test you have done it prior also. Now, advise how will you monitor. Now we have finally we have framed out this we have laid out this medical nutritional therapy, and after 2 weeks we will again do this levels to our postprandial glucose levels. We have given her a medical nutritional therapy, and we have decided that either we will go for a medical nutritional therapy, we can start on if that controls, and we can if that controls very good, we will continue with that. If she does not control, we will add on metformin. If it does not control, even after metformin or metformin is not acceptable, we can add on insulin. But all the whole point is, will I keep on measuring glucose? How long will I keep on measuring glucose? I don't want to measure glucose. So what happens is, you will advise pregnant women with type 1 diabetes to test their fasting, pre-meals, 1 hour post-meal, bedtime glucose levels daily. Type 1 diabetes patients are extremely important. But type 2 diabetes or gestational diabetes who are on multiple daily insulin, they need to fasting, pre-meal, 1 hour and bedtime daily. But advise pregnant women type 2 diabetes gestational fasting 1 hour post meal glucose if they are managing their diabetes with exercise alone or taking oral therapy. So this is basically known as 7-point sugars, and this is also known and 4-point sugars. We say this as 7-point sugar and 4-point sugar. Now 7-point sugars means that you measure fasting. I'm not able to annotate anywhere. I think I can annotate. Okay, yes, I think I can. So there will be fasting. Okay, this is one. Then you have a breakfast. So you will take pre-meal and pre-breakfast and post-breakfast. So some people mention 1 hour post-meal, and some we in our setup we do 2 hour post-meals. Okay, then you will have the lunch. So we will take prior to lunch and after lunch. Then you have a dinner. Then you will take prior to dinner and after dinner. So we have 1 level, 2 level, 3, 4, 5, 6, and 7. And sometimes we one fasting is basically before breakfast only, so that is 6 levels. And sometimes we measure at the 3 a.m. levels, but it is very difficult for the patients to have this wake her up and measure the 3 a.m. levels. So what we do is, just before sleep we measure at around 12, or whenever she sleeps just before that we measure the level, but ideally we need to measure the 3 a.m. levels. Okay, so this is important that I wanted to mention this. Uh, Now, in type 1 diabetes, you will do the 7-point, and in type 2 diabetes, you can do the 4-point. 4-point is that we don't do the pre-meals, we just do fasting, post-breakfast, post-lunch, and post-dinner. So these 4 values are more than enough. This is the only thing that monitoring you need to remember. And now these target blood levels, these are all millimole per liter. I need you, and I need somebody to immediately side by side parallelly translate these into milligram per deciliter online on Google, and may be able to tell us in the chat box, in the answer question box. I will write it here. Is somebody doing that? What is 5.3 millimole per liter? And what is 7.8 millimole per liter, and what is 6.4 millimole per liter? Because I want you to remember these values only. Multiply by 18. So please multiply and write the answers. Otherwise, I'll have to switch over to the next slide. Anybody writing? 95, 95. Okay. Then next, this is 95. This is a fasting sugar. Very good. 95. What is 7.8? What are our target one are 140. Very good. What is 6.4? That is going to be 120. Okay. 140 and 120. Why I want you to remember this thing is in millimoles per liter is 5.3, 7.8 and 6.4, because sometimes in your this is for your preparations. If you want to give any kind of exams, if you are targeting any exams like USMLE or any other exams like MRCOGs or PLABs or NEET exams, so sometimes they do not give they can alter, they can change their units. So if you know it since the beginning, so it is very good. If it is not mandatory, it is definitely not mandatory, but you need to know fasting levels. Target fasting levels is 95, 140 and 120. If you remember millimole per liter, it is good enough. If you don't remember, it is not mandatory. It just is a help, that is all, nothing else. Okay. So when we had admitted, irrespective she's type 1, type 2 diabetes or she is gestational diabetes, the management has till so far remained the same. Our management was to first do her monitoring, and monitoring diet and exercise. Usually type 1 diabetes are already on insulin, so we continue on insulin. Usually the ones who are on type 2 diabetes are already on metformin, we continue metformin. Or if she was already taking any other multiple medications, we will just drop down her to only metformin, or and if she needs diet and exercise. So it's a combination and everything. But when specifically you are being asked for GDM, gestational diabetes mellitus, you will start with an MNT. You will try for 2 weeks. If 2 weeks is successful, you will continue with that. And if it is not successful, you will add on metformin. If she is able to tolerate, or if she accepts metformin, you will continue with that. If she does not, then you will add on, you switch over to insulin. If she's not being controlled by metformin also, then also you will add on to insulin. And then we have told that target blood levels. How will you monitor? We have told. And monitoring of HbA1c has to be done at the booking appointment for all pregnant women with pre-existing diabetes. And HbA1c has to be considering second and third trimester with pre-existing diabetes only. In GDM cases, you don't need to measure diabetes HbA1c levels. Okay, so then we can leave all these things. Otherwise, now we come on to the insulin. Now, what does anybody know? What are the types of insulin that are available in the market? What are the types of insulin which are available in the market? So we prefer rapid acting insulin, that is aspart and lispro, for the pregnant woman. Long acting, regular, subcute. Subcute, you don't say subcute. That is a mode of mode of administration. Long, short acting, intermediate acting, very good. Short, regular acting, long acting. Now, what happens is, regular regular is the one which is intermediate acting, and then we have short acting, which are rapidly acting ones. These are aspart and lispro. So what happens is, if I have taken, normally what happens, we are able to have a standard diet, and if we are able to follow that diet, we can have static drugs, like we can, insulin can be fixed. बट हम तो इंडियंस हैं भाई, हमें तो भूख बहुत लगती है और हम लोगों को खाना भी बहुत पसंद है. So what happens is, there are chances to go up and down. अगर मैंने ज्यादा खा लिया, एक मैंगो ज्यादा खा लिया, mango has 200 calories and what not amount of sugars, so what we do is, we have rapid acting insulins. We have rapid acting insulin. Now rapid acting insulins are to be given prior to the meals to give you post meal, to maintain the post meal sugar levels. Okay, This is the target. Intermediate acting insulins, what they will do is, they will, given if before meals, they will, if I give intermediate regular insulin in the break, during breakfast, like previous, before breakfast, it is actually going to cover the entire period, because it will last for 6 to 8 hours. It will cover the entire time period and help cover till uh, immediately before the lunch. And long acting insulin will be covering the entire 12-hour period. So earlier, in the earlier years, what used to happen is, long acting insulin was when it was given to the pregnant females, and pregnant females, you, if by any chance you skip a meal, if by any chance you skip a meal, then the insulin is still there, it will still keep on acting, so there are chances of hypoglycemia. That is why long acting insulin, they are avoided in pregnancy. But if you have a very good, extremely good diet, and you know that nothing is going to happen, then long acting insulin is the best. So what kind of so once, if in theory you are asked questions, so you need to make a, you can either make a tabulated manner, which is given in your medicine book, what is rapid acting, insulin acting, and you need to know their duration of action. So rapid acting ones will be, ultra rapid acting ones will be within a fraction, within minutes they will start acting, and 2 to 3 hours they'll lasting. Intermediate will be starting at their effect will be between 2 to 3 hours, and maximum 6 to 8 hours. And long acting will be like 12 hours. So this basic you need to, you need to mention. Okay. And then glucagon is provided to women with type 1 diabetes only if they are needed, and she needs to know how it is needed. Then there is one aspect which is not mentioned here, which you need to know, is which is upcoming, is the insulin pump. Now, what is insulin pump? Is a subcutaneous pump which is applied. What I can do is, I can actually show insulin pump to you. It is important for you to know what is insulin pump. Insulin pump is, this is a pump which is, yes, like this. It is applied on the waist, and you can use it, continuously measures by a subcutaneous method, and it gives the insulin also. Okay, it gives the insulin also. So it is important for the females who have type 1 diabetes, who need to be on insulin. It is very good drug, it is very good. It's not really available in India as so far, but it is expected to get launched soon. And insulin pumps, what happens in pre-existing diabetes patients, insulin pumps are to be advised to be used 3 months prior to planning the pregnancy, because to get adjusted to it. So insulin pumps is a very good upcoming new thing, which you should be knowing. And continuous okay, next we have ketone testing and diabetic ketoacidosis. These are also offering ketone strips and meter in type 1 diabetes, you need to know. So type 1 diabetes are more prone to diabetic ketoacidosis. Now, what do you mean by diabetic ketoacidosis? Can anybody tell me what is diabetic ketoacidosis? In where the sugars, what are the causes of diabetic ketoacidosis? Why does diabetic ketoacidosis happen? There is a large amount of sugar which develops. Now, why will the sugar in the blood will be so much high? The sugars in the blood will be high because either you have skipped an insulin, you have eaten too much, you have non-compliance of insulin is there, you have got an infection, further immunosuppression, and all these factors are stress, very important, insulin dose skipped. These are all the reasons why diabetic ketoacidosis, and normally diabetic ketoacidosis in a type 1 diabetes will develop above 300. 250 is a target, 300. But in pregnancy, diabetic ketoacidosis, if she already has type 1 diabetes, she has a higher risk to develop DKA at a lower blood glucose level. She might develop DKA even at a 200 level also, 220 level also, milligram per deciliter. Anybody knows the management of diabetic ketoacidosis? You must have learned in medicine. So three things you need to mention. Fluids, extremely important. Somebody has mentioned fluids. That is the most important. Fluids. Okay, fluids. Next is potassium, fluids, potassium, and insulin. These are the three things you need to speak of. If you write these things, more than sufficient. Obviously in detail, I'm not speaking just just the words, no, but in fluids, insulin and potassium. And now sometimes what happens, if the patient is already hyperkalemic, then you can skip the potassium, you can just give insulin. Once the potassium comes in the normal range of 3.5 to 5, 3.3 to 5.10, then you may add KCl. And if the hypokalemia is then you can only give potassium and then skip the insulin for a while. And once the patient gets into the normal potassium levels, then you can start basically, then you can start the insulin also. And fluids, you have to give 10 to 15 milligram 10 to 15 milligram per kg per hour, 15 milligram per kg per hour in the first hour. And so for example, in the first hour you will give 1000 ml, and in the next 4 hours you will give 500 ml, 2 hours then you will give 500 ml, and the next 4 hours you will give another 500 ml. So this is how the fluid management is going to continue. And you will measure all these serum electrolytes is the most important. First initial stages, once the blood glucose comes in the normal range of less than 250 milligram per deciliter, till that time you will measure, keep on measuring the blood glucose every hourly. And even the serum electrolytes are to be measured very hourly. 2 hourly. And the retinal assessment during pregnancy, we have already discussed about that. Renal assessment during pregnancy at the first contact is to be done, and after delivery also. What happens is, if the patient has developed GDM, we first need to confirm, we also need to confirm that in the postpartum period she does not have the GDM. We call her GDM only if that she does not have any postpartum diabetes. If she has postpartum diabetes, so probably she had diabetes already and a very underlying, and the mass so subtle diabetes kind of thing, and the pregnancy basically unmasked is. So it is extremely important in the postpartum period to follow up all these things. And the retinal assessment you can skip, obviously you do not need it in the postpartum period, but we need to have in the postpartum period, we need to give it check the renal assessment in the postpartum period. Next, we have monitoring of the fetal growth. Now we have taken care of the mother for 45 minutes. I think 50 minutes we have just taken care of the mother only. Now we come to the fetus and offer the pregnant woman diabetes ultrasound and for every 4 weeks from 28 to 36 weeks. So every 4 weekly. So basically we will be doing 2 or 3 ultrasounds we will be doing, and we'll be monitoring the fetal growth. We have to see whether the baby is not growing too much. Macrosomia is also not there. We need to monitor that. Okay. And routine monitoring of fetal well-being before 38 weeks is not recommended in pregnant women diabetes unless there is risk of IUGR. So IUGR happens only in patients usually with type 1 diabetes, pre-existing diabetes with who have vasculopathy. Otherwise, GDM does not really have IUGR. GDM more often has macrosomia. And then we have these are all the appointments that you don't need to we don't really need to go through these, but intrapartum care. Now, timing and birth. So GDM pregnancies, if they're very good control, if they have a good control, any pregnancy which has good control on GDM has a good control, we can continue it till term, and we can terminate the pregnancy till 40 plus 6. Okay, 40 plus 6 it is we can allow over here. But after that we have to do elective birth. Like elective birth can be done by termination of pregnancy can be done by induction of labor. We don't have to go cesarean. Okay, she's has a macrosomia, so we go for cesarean. So, but if there is macrosomia and diabetes, then we will definitely go for that. And but in outside India, we consider macrosomia to be 4.5, and in India with diabetes, we consider it 4 kgs. Okay, then we have advised pregnant women with type 1 or type 2 diabetes and no other complications, elective birth or induced labor by cesarean, or if indicated by cesarean, at between 37 and 38 plus 6. So type 1 diabetes, already pre-existing diabetes, are not to be continued beyond 39 weeks. Okay. And if they have metabolic compromises or fetal complications or maternal complications, then we would like to deliver the mother before 37 itself. But no, let GDM should be, or GDM also will not be extended beyond 41 weeks. So this is the only thing. And as the blood glucose during during the labor, you have to monitor. You maintain it between 4 and 7, again basically 120 and between 70 and 120, that is the target. 70 and 110. So what happens during labor, you will measure hourly sugars levels. Okay, and your target is between 70 milligrams per deciliter and 120 or 110. So If it goes below, then we will start a dextrose fluid. If it goes above, we can start a normal saline fluid. Fluid management is extremely important. Fluid management, lung maturity in early induction. I'm not understanding the question. Lung maturity in early induction. So this is a very controversial topic to give. Do we need to give dexamethasone and steroids for lung maturity if we are planning early induction? So induction, if basically vaginal delivery itself helps to decrease the risk of TTN. So if we are having a planned cesarean for any patient at 37, 38 or 39 weeks, we would like to give the patient a steroids irrespective of GDM. But if we are doing an elective induction, we may be able to skip that. Okay. And as we discussed, if the levels go below the 70 milligram per deciliter, then we would like to go for dextrose infusion and DNS. And if we the blood sugar levels are more than 110, only normal saline would be suffice. In between 70 to 110 sugars, we would can till the time she's drinking orally, that is good enough. But if she needs IV fluids, we will go for an intravenous dextrose and insulin infusion fluids, which is called as a GI drip. Okay, and now the baby, as soon as the baby is born, the resuscitation, we should get the baby born in a advanced neonatal resuscitation skill hospital. Okay, because the babies are at a risk of so many things: hypoglycemia, hypocalcemia, hypomagnesemia. There's a whole list which is given in your datta that you need to remember. So admit babies of the women with diabetes if they have hypoglycemia, respiratory distress, neonatal encephalopathy, polycythemia, and you will not transfer to the babies of the women and at least till they are 24 hours. So basically 24 hours observation is minimum necessary. And how will you prevent the hypoglycemia in the neonatal period? Can anybody mention that? How does in India it works? How will you prevent neonatal hypoglycemia? Please write in the breastfeeding. Very good, extremely good answer. Diabetes has to, the neonatal hypoglycemia should be managed by more often, frequent breastfeeding. In fact, you will not even wait for on-demand breastfeeding. You will wake the baby up after 1.5 to 2 hours and you will tell, okay, baby, drink. You have to make the baby drink. So at frequent intervals, we will also check for the baby's sugar levels, and sugar levels for baby is around 45 to 50 milligram per deciliter. That is the target. And for babies, clinical signs of hypoglycemia, test the blood glucose level and then provide intravenous dextrose as soon as possible. In the postnatal care, again, with the women who are insulin pre-treated, pre-diabetic patients, you will reduce the insulin immediately, because as soon as the baby has delivered, your requirements, because the baby was taking so much glucose in from your body that you are requiring more insulin, but the insulin demand decreases. So you will you will go down to 1/3 levels of insulin. You will decrease the insulin immediately after birth and monitor blood glucose level. But if she was not insulin, GDM, you can skip whatever she was. If she was taking metformin, you can skip that. If she was taking insulin for GDM, you can for a while you can stop the blood glucose lowering therapy immediately after birth. Okay, and then after third day you will measure in third for a while. If she has having cesarean section post operatively, since she'll be NPO, she'll be not taking anything by the mouth. So that in those case scenarios, you will continue the fluid. So you will keep on measuring the blood glucose levels, maybe time again 8 hourly or 12 hourly you will measure the blood glucose levels. But once she is orally, then you can skip it. And third day, in women with GDM, you need to definitely measure a third day fasting sugars, and then after 6 to 13 weeks for to know whether she is diabetic, to exclude diabetes. So 6-week postnatal checkup is the cutoff, and we do not do a OGTT at 6 weeks. We just do a fasting sugars. But if she is not ready to get a fasting sugar, we can just do an HbA1c also. So if now if they are on the normal levels, we will tell her that she has in the next 5 years, and if she's obese also, and she in the next 5 years she has a risk of developing diabetes 50%. So what we will advise her to have a lifestyle advice. We will give her a lifestyle advice of weight control, diet and exercise after the birth. ऐसा नहीं है कि उसके बाद आप गुलाब जामुन खाते रहें, वो नहीं करना है, ठीक है. And HbA1c can also be used for a measurement. I think we have covered the entire aspect, and this is the life approach of prevention of diabetes. ये मुझे बहुत अच्छा मिला था. so I just kept it. So if the offspring is girl, since even if she's unmarried or she's female or adolescent girl, all below 30 years, there has to be a community assessment of GDM risk factors and lifestyle changes since the beginning itself. And all non-pregnant adult women more than 30 years. So further excessive, you can do the screening and diagnosis also, management. Though we are not following all these things, in the pregnant women in community, DIPSI criteria has to be used as per the MOHFW Government of India guidelines. We know universal screening has to be done, and MNT for 2 weeks, and after 2 weeks, 2 hour postprandial glucose. We have done that, and we need to keep our target levels where we discussed 95, 140, and 120. Those are all the things that you have to remember. In postpartum women with GDM during pregnancy, you have to explain her post-managed management of diabetes and screening of diabetes if you had GDM, lifestyle advice, breastfeeding, and contraception. All sorts of contraception you can give to these patients. I think this was it in this thing. This is also, I think we have covered pretty much it. Any doubts, please message. I think we are done 1 a.m., 9 a.m. and I already started first. Okay, these were in the MNT part. I skipped this. This was important, that how the MNT has to look like. The MNT, if the female is not if the female is not overweight in the normal BMI range, then we will go to 2000 to 2000 kilocals, 2000 to 2200 kilocals per day we can give. But if she is obese, overweight and obese, then we will go 1200 to 1800 kilocalorie diet. So important is basically 50 to 60% should be carbohydrate, 10 to 20% should be proteins, and 25 to 30% should be fat. This is an ideal diet, that half portion of thali. This is an Indian diet. This is a graph which we have how to start insulin and all in GDM. If she is not controlled, we start with intermediate insulin. How do we start intermediate insulin? Is 30 to 70. This is how do we decide the doses. But I think it's okay. Then we have done the role of ultrasound. Level 2 ultrasound is extremely important, no doubt. And we have done that we should assess the fetal growth beyond 28 weeks. And okay, oral hypoglycemia we do not give. Only which can be given is maximum that can be given is. So national guidelines metformin we discussed that it is an off-label use. Okay, it is an off-label use. I think we are timing and mode of delivery follow-up is also done. So we don't do a 2 hour 75 OGTT at 6 weeks. So don't do that. Okay, postpartum period is not to be done. I think I'm done. Okay. Any questions? I've not asked. I've not found any questions. Any feedback? Please write in the please write in the question chart. I don't think so. We have these are all complicated questions. These are all PG level questions. So we will skip all this. Good. Okay, ma'am, since DIPSI is followed, so that means OGTT is not done now. No, in India we don't do. We don't do. More importantly is, OGTT is 75. It is very complicated. I have had so many patients in my own this experience that the patients vomit out because how we explain them is like 250 or 300 ml of water we take and we then add 75 gram. And earlier we used to do 100 gram also. 100 gram glucon D we used to mix in it, and she has to drink that entire 200 300 glucon D in 20 minutes. Try this at home once. You will realize how difficult it is. And that too with pregnancy and all that baby inside, the big baby inside. It is so difficult for the pregnant female that there are so many cases of vomiting. So basically, the false values come. So there is no point in. So this is the DIPSI is chosen not just for the effectivity, it has a higher sensitivity. You pick up more cases, that is definitely care, but it is more comfortable also for the patient. There is no fasting needed. There is only one value needed, especially in COVID times when you do not have multiple exposure to the patients. Also, you cannot keep on going after 1 hour, 2 hour, 3 hour. You cannot keep on doing that. So instead of that, only one value is best. 2 hour sample has to be taken. That is the best. Okay. Okay, good. I'm glad that you found the session good and you learned a lot. So we will meet at 1 p.m. for that class. What is the topic? I've also forgotten that. Adolescent wala. Okay. Okay. Thank you, bacho. Thank you. I don't even know how to end the class. Can anybody tell me please how to end the class?